Wow. Hello, British Columbia. Thank you to Christine and the entire Quality Forum team. This has been an incredible experience. What an amazing conference. I've been so impressed with all the work here, especially the attention given to the First Nations. It's incredible, and I want to bring everyone from Boston up here to learn about this. Unfortunately, I do not have a picture of my daughters on a beach in Vancouver. One of them is barely crawling, but I will come back and get that photo one day. You might be asking yourself what a resident is doing up here. After all of you likely have more experience than I do in quality improvement, in leadership, and in healthcare in general. But as a senior resident at a major safety net hospital in Boston, I think I can bring to you a slightly different perspective, that of QI from those of us who tend to spend a great deal of time on the front lines of healthcare with patients and yet have the least influence, students and trainees. What if I told you that a silent epidemic is taking place, a disease that's affecting over 70% of medical residents, and that this likely reflects a similar prevalence in all other disciplines involved in healthcare, nursing, physical, occupational therapy, social work, pharmacy, everyone? What if I told you this disease presents with everything from fatigue, headaches, insomnia, nausea, GI complaints, depression, and yes, even suicidal thoughts? What if we knew that it's correlated with elevated inflammatory biomarkers, and it impairs functioning and work so much that for patients cared for by afflicted providers, they have worse patient satisfaction scores, longer post-discharge recovery. Overall, their care, I think, is worse. The epidemic is real, and the disease is burnout. Research suggests that there are three components to burnout. First, an existential crisis, the loss of meaning in your work, the feeling that you're not skilled enough or that what you do is irrelevant at best and harmful at worst. Next, emotional exhaustion, feeling overextended, exhausted to and beyond the point of breaking. And finally, perhaps worst of all, a sense of depersonalization, which I think of as a fundamental disconnect between providers and patients. The way that we deliver healthcare, I would say universally, attacks the very core of our identity as healers. It casts doubt on our skill, it pushes us to exhaustion with paperwork, and it turns the once nearly sacred relationship between patient and provider into something monstrous, where sick patients are turned into a litany of diseases and checkboxes that stand between you and any sense of joy. Hopefully, I can convince you of a few things today. There's a real crisis of burnout among students. It is a systemic problem, and the victims of this problem are integral to the solution, but that solution isn't possible without all of you. We all know that QI requires frontline Gemba experience. Trainees can contribute this in an incredible way. Engagement in quality improvement can absolutely build resilience against and perhaps even reverse burnout. And again, this is only possible with all of you in this room today. I'm going to tell you three stories that show how real these problems are. First, how do systems failures rob us of our professional identities? I remember the hallway being eerily quiet. I walked in the room and, without thinking twice, I knew. My patient was dead. I had let a man die under my care, and I was a terrible, terrible doctor. Let me back up. 2 years ago, I was a first-year internal medicine resident. I was just months from getting my MD diploma. I was taking care of Mr. V, an elderly man with kidney disease. He was on dialysis. He had chronic vascular pain, mostly in his legs. But just a month earlier, he'd been totally independent, living at home alone and working at H&R Block doing taxes. On one of my first visits, he looked at me and said, "I want someone to put a gun to my head and pull the trigger." I was totally caught off guard, and something was clearly wrong. His family came to the bedside. They said, "This isn't him at all. Something's wrong. Figure it out." And we couldn't. I was at a loss. I couldn't figure it out. None of the providers taking care of him could. He floundered on the service, just getting worse and worse, sicker and sicker. And 14 days after he was admitted, a week after I had assumed his care, we finally made the diagnosis. About a month earlier, as a high-functioning individual with pain, his PCP had prescribed extended-release morphine. The drug was excreted from his kidneys, but he was a dialysis patient, so he was dependent on the machines to clear toxins. The medication made him sleepy enough that he missed dialysis once, and that led to a downward spiral. So perhaps an error was made that day that landed him in our hospital, sick and confused. But the worst part of this story is that day after day after that error, in my hospital, morphine was still on the patient's active medication list. It was given to him twice a day for over 2 weeks. The poison was building in his body right under our noses, and we were clueless. We fixed the error for Mr. V. He became lucid. He became back to his old self. He wanted to live, but it was too late. A few mornings later, he complained of chest pain. I saw him. I stepped away to order an EKG. I came back just moments later, but I knew right away that he was gone. There are 2 lessons I want to emphasize from this story. First, think about the impact this had on me as a young provider. I had just started my career as a doctor. Suddenly I was faced with the overwhelming reality that I was responsible for a medical error that led to a patient's death. Imagine feeling that you alone were responsible for a death. You would worry that it would happen again. You would worry that you were the problem. What kind of doctor was I going to be? I worried that more would be hurt under my care, that in this complicated system with sick patients were bound to get hurt. From that day, I started to have a lot of trouble making decisions. It really got to me. It made me question the meaning of my work, and it was the beginning of what I would really call an existential crisis. It's just months into being a doctor. Second, at its core, this was a systems error, as I'm sure many of you can recognize. All of the usual safety mechanisms fell apart, and the error sped through that Swiss cheese with tragic results. It wasn't the fault of any one provider. More than 5 services with Boston's best doctors, residents, and medical students were caring for the patient, including pain medicine and kidney specialists. The pharmacists who were experts with these medications looked at the list every day. Nurses who I honestly trust my own family members with gave the drug twice a day without any hesitation. Nearly everyone was involved and no one caught it in time. I would say that passes the substitution test. So this story shows us how a systems error led not only to a tragic outcome for a patient, but also the beginning of a deep erosion of my own self-confidence, even going so far as to convince me that my work was meaningless. It ate at the core of my professional identity, and unfortunately, it wasn't just happening to me. As part of a research study, I surveyed 3rd and 4th year medical students across the US. I asked them how the experience of systems errors, specifically deficits in quality, changed their perspectives of medicine. They spoke openly, and their vulnerability was obvious. This is what you don't hear, what you don't want to know. This is the way that an outsider sees our system. And worst of all, this is the impact it has on our future physicians. Is this how we want our doctors to think? Simply put, the answers were terrifying. They covered the spectrum from harm, delays, inequitable care, a worrisome deviance from evidence-based practice, and worst of all, they spoke of the absence of patient-centered care in their own practice. It was shocking to me how many students specifically said they were jaded. That word, jaded. Deficits in quality alone made students apathetic, burned out, at a point when we expect them to be the most enthusiastic, the most optimistic. This is what our future healers are thinking before they even enter practice? What happens to them down the road? You all know them. They're the barriers you face in every improvement project. The naysayers, the apathetic, the inertia of the status quo, that's them. We're building them. This is how the system's problems lead to residents who give up on healthcare before they've even started. Why is this happening? Well, as we all know, every system is perfectly designed to deliver the results that it produces. And the front lines produce burnout in trainees and veterans alike and in almost any field of healthcare. We have institutionalized burnout. Students and trainees in healthcare live in the broken system and are expected to fill in its many, many gaps. We document endlessly on the EMR. We spend hours faxing medical records, calling clinics, doing whatever it takes to make sure things get done, to make sure the system keeps moving. Because the current system leaves so much undone. Unfortunately, the consequence of so much time spent working around the system is much, much less time spent for patients. Less time at the bedside, less time managing complex medications, less time when you are juggling many sick patients from shift to shift. And then we make errors, as I did with Mr. V, and we feel deeply, profoundly responsible. But it gets much worse than that. The truth is that systems failures are soul-crushing to trainees, not just in these dramatic instances, but even more importantly on a day-to-day basis, as the insurmountable odds stacked against us grind us down. The system's failures don't just hurt our patients, which they do. They hurt our workforce too. One of the physicians I look up to most, Paul, he was an intern with me on the general medicine service at our city hospital. We were taking care of a classic city case, a man with a long history of IV drug use. It was complicated by a very difficult to treat infection in his bones. He was admitted to our hospital for this problem, infection in his bones. Paul got to know him well over the course of his admission. His addiction was a major problem, but he knew he had to get the infection treated. He got an MRI at our hospital, which showed, unfortunately, that it looked like the infection had progressed. The team with infectious disease doctors and orthopedic surgeons, general practitioners, we needed to know more. Was this a major change from his last scan? Well, the good thing is, his last scan was performed at another major academic hospital just blocks away. Every hospital in Boston is just blocks away. We needed a copy of those images on a CD to make a decision about surgery. No problem, right? Just a CD. Paul got to work. He found the right person in medical records, completed and faxed the request, received the report without the CD. He sent it again and called, still no CD. He calls again. Apparently there was a problem communicating between the medical records person and the medical record person that makes CDs. Finally, a CD is made, and it's sitting there, but they're having problems shipping it a few blocks away. Day after day, Paul stands there, and I'm watching him at the bedside with his head hung low, telling the patient, who is clearly fighting the urge to use heroin despite our best efforts, that we need more time. We just need a little more time. Paul realized he was getting nowhere. at 5 a.m. on one cold, dark winter morning. Before his shift, Paul got on his bike and headed over to the other hospital where he effortlessly picked up the CD. They were so happy to help. We got the films, he came back, and we had a plan: surgery. Paul walked into the room proudly the next morning, only to find an empty bed. The patient had eloped, probably to use drugs on the streets, and we never saw him again. He checks to see what's happened. He hasn't come back. Now, that is soul-crushing for an intern with the best intent. Honestly, he has a heart of gold. And he's going to such effort in almost a heroic sense to help this patient, only to find that the patient just vanished, that all his effort was for nothing. I say heroic because at my program and at many like it, we literally give each other accolades each week for those who put the extra effort into overcoming barriers in the broken system. These are real examples from my hospital. This resident scrambled to complete paperwork so that a patient could get an MRI scan and not have to stay in the hospital an extra day just waiting for a test. She got catheterization records from another country. This guy, the EMR was down, the whole network, everything was down. What does he do? He hotspots with his cell phone so that he can look up the records and write notes. Unbelievable. She picked up her patient's medications and paid for them. And this was one of my favorites. He rented a zip car to drive a patient's meds to his rehab. Unbelievable. These are amazing stories, and I'm so proud of my colleagues for their efforts. But this incredible energy is spent on systems failures, not at the bedside helping patients. Imagine if dealing with these barriers was the rule, not the exception. What if it consumed most of every day? Being the workaround for our fragmented systems does just that. And eventually we all face the reality that our hardest work is often for nothing. This is how our trainees become emotionally exhausted by depleting their energies on absurd tasks instead of caring for patients, and finding that those efforts are so often in vain. The system doesn't just impede us, it pushes us, actually pushes us to stop caring. I've demonstrated that these systems errors lead us to lose confidence in ourselves and set us up for an existential crisis. And I've shown you how trainees are leveraged as workarounds for the broken system on a routine basis and how that exhausts us. Next, I'd like to use the patient and family perspective to show you what exactly depersonalization looks like and how it is absolutely the result of failed healthcare systems. Last May, a flash flood warning in Boston caused everyone's cell phones to buzz at precisely the same moment. That was apparently the sign that our baby was waiting for. My wife called me at work with the news. What? Your water broke when you got the flash flood warning? It really happened. Apparently, our daughter has a sense of humor. This was our second baby. Our first was delivered at the same hospital on the midwife service, and despite a long and extremely difficult labor on my wife's part, it was a fantastic experience. It was truly patient-centered care, and we were deeply, deeply appreciative. But this second time around, things felt different from the very start. They didn't listen to our request to be placed on the midwife team. Hours later, my wife's labor wasn't progressing. It was going even slower than the first time. And it seemed like from the first conversations we had, the doctors were already leaning heavily towards a C-section. Perhaps there was good reason for this. I'm sure there was, but it certainly was not communicated well. Instead, we felt alienated from the team, adversarial. Really, we felt that way, adversarial. Finally, there was a concerning finding on the fetal heart tracing, and they advised urgent surgery. The next thing we knew, after consenting, there wasn't really a discussion of alternatives, my wife was whisked into the OR. Before we knew it, our baby burst into the world, beautiful and shrieking loud enough for the entire city to hear, something she still does. I raced upstairs with baby to the nursery, spent a few minutes with her, skin to skin, I got to do it, and then ran back down, only to wait and wait and wait outside the OR. It felt like ages. And I started to get worried. I realized that I had no idea what was going on beyond those doors. It was surgery, emergent surgery, and anything could happen. I knew anything could happen because even in my limited training, I had seen too many tragedies from emergent surgery. I realized that I could really lose her. It was overwhelming, the fear, and I had never felt anything like it before. It was crippling. Finally, the doors opened, and my wife was wheeled into the recovery room. I knew the second I looked at her that something was different. She looked like a ghost. My daughter came down, she's scrambling on top of her. My wife cracked open her eyes, smiled faintly, and she was back asleep. She couldn't even lift her arms up to hold her daughter. It was so scary. It was so scary. The next day, we found out that her blood count had dropped from 12 to 6. She had lost half the blood in her body. She was pale, weaker than I had ever seen her, like a shadow of herself. The next few days in the hospital were awful. We had just gone through one of the most frightening and intense experiences of our lives, and everyone seemed incredibly nonchalant about it. When we asked the providers, they said, "Well, we're used to seeing a lot of blood loss. At least she didn't need a transfusion." Really? The providers were universally abrupt. They barged in at any moment's notice with no respect for a new nursing mother, a sleeping infant. Everyone had the attitude of, "Well, I need to get X, Y, and Z done, and what you're doing is irrelevant." The unit had instituted quiet hours, a mere 2 hours in the afternoon. You couldn't pick which 2 hours. Those were the 2 hours, 2 to 4 p.m. And they were protected from intrusion so that mother could rest. And it was broken just about every day by some doctor or another. There were countless people entering the room. OB attendings, OB residents, pediatric attendings, pediatric residents, medical students of all varieties, nurses, nursing students, nursing student instructors, lactation consultants, registration. It was endless. I didn't even know who half the people were, and I work in a hospital. But seeing healthcare from the perspective of a patient and family, we were not impressed. We were not impressed that our physicians couldn't time their rounds under my wife's very limited ability to sleep. We were not impressed by the number of times a nurse looked at us and smiled and said, "I'm sorry, honey, but that's just the way we do it here." We were not impressed by the fact that every single person, except the man delivering our food, God bless him, barged into the room without knocking. Every time, it was flawless. No one seemed to care that my wife was struggling to create the incredibly important bond between a mother and her new baby. This is what a systemic failure of patient-centered care looks like. And I'll tell you what, it is a systemic problem, not just a bad batch of doctors and nurses. Consider knocking on a door. Knocking is, to me, one of the clearest examples that you accept that you are a guest in the life of the patient. By not knocking, you are setting the tone from the outset that the patient is a guest in your hospital. They're here for you. I realize that in the 6 or so hospitals I've had the chance to train at in my very short career, I almost invariably entered patients' rooms without knocking. The entire team did. It wasn't even a thought. And it's not the fault of any one provider, and it's not the fault of any one hospital's culture. It's more than that. These providers want to spend time with you. I want to spend time with you. But the system pushes us to brush past knocking on the door and brush past everything else to get back to what? Our computers. The crushing inefficiencies of modern healthcare put documentation at the top of every list and leave the patient fighting for a spot at the bottom. We all go into healthcare because we care about patients. This is healthcare. But when we're ultimately forced to decide between spending an extra 5 minutes at the bedside or staring at a computer screen, we pick the computer screen every time. Because we have to. Because if I don't finish my check boxes, the patient won't get the tests they need. Because the night team will be left with half-finished work. And because if I don't finish my documentation, I don't get to see my kids because I'll be stuck at the hospital after hours writing notes. It isn't a decision, it's a necessity, and I feel totally incapable about doing anything about it. We institutionalize the creation of technicians in those who dreamt of being healers and who train for a decade or more for that purpose. It destroys our identity. It absolutely burns us out. And then, after rushing past a patient one too many times, you start to forget that they're people. They're just diseases with tasks that need completing. And you start to snap at the patients. You're irritated that they're in your way. Then you start to see them as the enemy. I'm sure all of us have felt like that because I felt like that. It should never be like that, but it is exactly like that far too often because our systems devalue patient-centered care. We've institutionalized burnout in the training of our providers, and this is due to systems failures. With my story about Mr. V, I showed you how errors undermine our confidence and set us up for an existential crisis. Paul's heroic struggle to get a CD from a hospital across the street, you can see it from the window, demonstrated the incredible barriers that are in our way of caring for patients and how those barriers wear us down day after day until we're totally spent, too exhausted to care. And finally, my family's experience with poor communication and callous providers shows us that it has disastrous consequences when the system pushes our providers against patient-centered care. What do these 3 stories have in common? They show me the dichotomy between the provider I want to be and the one I'm allowed to be. And what they really highlight is the lack of any sense of control, the intense feeling of being powerless. Feeling powerless is the foundation for burnout, but the opposite is also true. It's something more when you're not powerless. So what happens? What happens when trainees don't assume that the system they're given is the best it can be? A precious few medical students responded to my survey like this. We need every student in healthcare to respond to systems deficiencies with this kind of enthusiasm. We need them to look at any system, even a good one, and assume that it can be better. Most importantly, despite all of these problems, they tell us that they are still here for the patient. They are anything but jaded. What's different? Perhaps they are not so different from all of you who approached healthcare, saw its ugliest problems, and decided to take action for improvement. In fact, the answers to all of these questions was clear. We are going to fix this. This is going to be our life's work. This is the attitude of what I've come to call Generation QI, the results of your efforts as the leadership in healthcare improvement to make improvement science accessible and to make the problems transparent. Your example has had a tremendous effect. Take me. In medical school, I was never taught anything about quality improvement. It hadn't made it there yet. It has now. But I heard about the Institute for Healthcare Improvement one day. I began to learn about improvement science on my own from the IHI Open School. I got involved with local QI projects, and thanks to people like you, I got to sit on some administrative committees that oversee the care we deliver. In all cases, I have been absolutely floored by the enthusiasm and optimism that everyone in improvement has. I mean, look around this room. Think about the past day and a half. The energy is insane. Why don't we have that in the hospital? The most important thing I learned from your generation, the creators of healthcare improvement, is how to be what Don Berwick calls a systems thinker. Always curious about the big picture, about what happened around the patient, sometimes invisible to our clinical eye. What created these circumstances? This has been the single most valuable tool I've developed in building my own resilience against burnout, and it has paid incredible dividends. Not only am I able to resist the negativity of modern healthcare, but I've learned that I can do something about it. I can use my clinical experience to inform systems improvements. I can, and we do, institute systems for safer handoffs, for medication reconciliation, for everything we can to make sense of a busy and complex healthcare landscape. Let me give you a small example of what it's like to be an empowered trainee. In July, I had the privilege of caring for Mr. S., a 70-year-old Navy veteran who served in Vietnam. Mr. S. presented to the hospital with fatigue, and he was ultimately found to have an advanced infection, an abscess around his spinal cord. His course was unfortunately complicated, and over a few weeks, the infection progressed. He was paralyzed in our intensive care unit. Try as we might, we couldn't get control over the infection, and eventually, we knew that he was dying. His entire family was with him on a daily basis, and the show of love and support from them was just incredible. And they knew too. They knew. He had a profound effect on our team. Despite his progressive and steady decline, he was clearly full of love for the family around him and grateful for the care that we were giving him. He had only one request for his family and for our team. As a lifelong lover of the outdoors, his desperate wish was to not spend his final moments indoors in a hospital room under the fluorescent glow and shrill alarms of modern medicine. He wanted to be with nature. Easier said than done. It was a massive effort. It required great coordination. He was far too sick to make it home or survive any kind of transport. He wouldn't have made it anywhere outside of the hospital. Besides the medical team, nursing, palliative care, respiratory therapy, social work, everyone was involved to coordinate this plan, to take Mr. S. outside on his hospital bed to the edge of the parking lot where he would be surrounded by the great trees around our hospital. It was stressful, it was difficult for all of us, but we managed it. We took Mr. S. outside on his ICU bed with a portable ventilator. His family and a small clinical team accompanied him. When we reached the edge of the parking lot, all he could see in front of him was enormous green trees and a brilliant blue summer sky. And I swear, a large brown hawk actually circled overhead. It was amazing. The medical team communicated silently. The nurse was giving pain medication, the respiratory therapist was managing the ventilator, and at some point he slowly fell asleep as the medications sustaining him were weaned off. We looked at each other and we knew the time had come. The ventilator was disconnected, and Mr. S. took a breath of the warm summer air. it would be his last. Looking back, it was possibly one of the most beautiful moments of my medical training. One of the most elegant displays of modern medicine, not an act of curing, but a relief of suffering and the preservation of dignity. It was care that was coordinated so flawlessly that we broke down innumerable barriers. It had never been done before at my hospital to do something truly meaningful. It had an incredible impact on the family. They were so grateful that his wishes were actually followed. Being a part of that, a small part of it, was absolutely energizing for me. And even though I only played a small role, I had a great sense of control. Like, what I did mattered. It mattered for someone. It starts with you. The first step to creating true joy in our work in healthcare is to create a society in which every member of the care team is a systems thinker. How are we going to make that happen? It starts with training. It starts with you. We need to rally this legion of trainees to be a generation of QI-minded healers, ready to take on the seemingly endless but critical work that needs to be done. And eventually we'll see more accolades like these. Again, real accolades from my hospital. Exceptional bedside manner. Incredible physical diagnosis skills, actually putting your hands on a patient. Literally saving lives on the streets. These are the acts of heroism we should be celebrating in modern medicine. It isn't a dream for the future. Trainees are already energized about improvement. Some 200,000 students, future physicians, nurses, administrators, pharmacists, therapists, social workers, everyone. They've created a community of hope, energy, and excitement. It is incredible. With almost 700 chapters in 70 countries, the IHI Open School is truly a community for change. And they're here in this room. Can we have a round of applause for the students? I hope you saw their posters. They were awesome. The community in the open school, all of us, will be fixing healthcare from the bottom up. One PDSA at a time, we'll be highlighting the gaps that we see every day in our work, the gaps in quality, the inefficient care, unsafe processes, and everything that deviates from evidence-based medicine. We see it all the time. And in doing so, we will force the policy change that will begin to fix the roots of our broken healthcare systems. But we can't do this without your help. As leaders here in British Columbia, I ask all of you here who have already made such a commitment to improving healthcare to take it a step further and to commit to engaging with your students, your trainees. If you don't have them, find them. They're here. Remember that if you are a leader in this room, as all of you are, you're also an educator and a role model. Having influence is critical to not being burnt out, and only you can provide that. Teach them to be systems thinkers, and in doing so, build their resilience. Involve them in your improvement efforts, and in doing so, utilize their frontline, unbiased perspectives to make meaningful changes. Push them to succeed and help us to turn Generation QI into the healthcare leaders of tomorrow. And we will make healthcare about healing again. Thank you.